Thank you so much, ma'am.
Ma'am, what is the score?
Score is now 27.
Okay.
27. So I think we just wait for 2 more minutes, and it's 8:30 now. So we will start in next 2 minutes. I'm expecting people are joining constantly. Actually, I've realized that many of the people even forget, they want to join, but they forget that they were supposed to join.
Few minutes to register also.
Yeah, few minutes to register also. So that is why today Reena has opened it at 8:15.
Yes, ma'am. First of all, good evening all. I'm thankful to everyone for giving me this opportunity again to present a case on this platform. So today my topic is epicardial fat. It is a very normal feature of the heart. Every heart has some degree of fat attached to the epicardium, especially in certain region. So epicardial fat is a kind of adipose tissue. Let us discuss the epicardial adipose tissue morphological features. It is a part of visceral adipose tissue which is metabolically active, found between visceral pericardium and myocardium. It is more prominent in atrioventricular and intraventricular grooves, right ventricle lateral wall, and along coronaries. It exerts paracrine and vasocrine effects on coronaries as no facial plane. A range of pro-inflammatory cytokines oblique adipokines are secreted, which leads to plaque formation, endothelial dysfunction, vascular inflammation. It has both protective and pathological effects. It is commonly seen in obesity, diabetic, metabolic syndrome, insulin resistance, and becomes pathological. It leads to coronary atherosclerosis and left ventricle hypertrophy with diastolic dysfunction when pathological. It also has some protective function. It functions as a cushion and mechanical. It acts as an immune barrier. It provides mechanical protection to the coronary arteries, providing space for arterial wall expansion in the early stages of atherosclerosis. It is a local source of fatty acids for the myocardium during high demands of movements. It acts as thermogenic effects related to brown adipose tissue, save heart from hypothermia. It acts as an immune barrier, protecting the myocardium and coronary arteries from inflammatory and pathogenic substance. Measurement of EAT on echo. What is the recommendations for measurement of epicardial fat? It is identified on standard parasternal long axis and short axis view, anterior the right ventricle, where echo-free space is visualized. It is measured in the end systole when heart contracts and fat pad become more evident. Then it should be measured perpendicular to the right ventricle free wall. It ranges from 1 mm to 23 mm. One should take an average of 3 cardiac cycles for measuring in both the views. Subcostal window provides a good view to measure epicardial fat anterior to the RV free wall.
Rashmi, go back. You have missed two important things. It has to be measured in end systole, and
Yes,
that the
ma'am.
average of both the views should be, actually considered to give a final value. All
Yes, ma'am.
right. While we
Yes, ma'am.
measure average of both the plaques and the sacs views, whatever you get to measure, you need to take an average. And while the heart is contracting at the end, the recommendations are that it should be taken in the end systole.
And systole. Yes,
Yeah.
ma'am.
Go
Yes,
ahead.
ma'am. Limitations. Let us understand the limitations of epicardial fat measurement by echo. As we know, echo shows two-dimensional structure of heart, so it is difficult to measure the volume by echo. There is no standardization of measurement, no standard cutoff values, so more validation is required for the cutoff values. Hence, the epicardial fat can be underestimated. Therefore, CT and MRI are better modalities to assess. Biomarker of cardiovascular risk. Why epicardial fat gaining more importance? It helps in risk stratification. It has been found to be very, very significantly correlating with the thickness. Epicardial fat is an upcoming non-invasive biomarker of assessing the cardiovascular risk. Its thickness and volume independent predictor of major acute cardiac events, myocardial infarction, cardiac death. In studies, it is found that thickness of more than 5.45 millimeter in patients of STEMI predicts moderate to severity of CAT and high coronary thrombus burden. In type 2 diabetes mellitus, eat more than 5 mm is associated with 5.38-fold increased risk of CAD. It also has potential for therapeutic monitoring. It is a dynamic fat deposit, so echo monitoring is effective in follow-up of weight loss regime, bariatric surgery, pharma intervention.
I'll pause you here, Rashmi. Just go back.
Yes.
Okay,
Yes, ma'am.
so here the idea of emphasizing this is actually the result of many meta-analysis done in 2025 on this important predictor of cardiovascular risk. And it has been found that a thickness of around 5.5 and 5 to 5.5 has been found to be associated with a very high risk. All right. So, and in diabetic also, with the increasing thickness, the risk of CAD increases. Now, a very important thing is, see, echo is a very easily available, easily done procedure. So evaluation of risk, because every time we are struggling that how do we risk stratify our patients so that we can initiate, we can give primary prevention to such patients. So it is very essential nowadays. Obesity, lifestyle problems, these are increasing. So we find that a lot of cases of metabolic syndrome and diabetes, obesity are on increase. So it is a very, very last point is a very, very important message that if we are doing some kind of weight loss regime, following that, following a bariatric surgery, following some kind of pharma interventions like GLP-1 analogs, which are also given for weight reduction. So, like, then how will you follow such patients? So, as it is a dynamic fat deposit, so it will keep increasing and decreasing. So is there a response to what is being done? It is a very good tool, so, and has a lot of promise in following up the patients. Go ahead, Rashmi.
This is a picture presentation in which this yellow color is epicardial adipose tissue, which is predominantly surrounds coronary blood vessels and is situated between the myocardium and the visceral layer of the pericardium. This red color dotted area anterior to the right ventricle shows equiescent area, which is epicardial fat. And in this second picture, above this red dotted area, which is epicardial fat, the yellow dotted area occupies the pericardial fat.
So epicardial fat and pericardial fat are two different things. We must understand that. Pericardial fat is also, sometimes labeled as pericardial fat. It is outside the pericardium, whereas the epicardial fat is inside the pericardium. So both the things may coexist, as you can see in this image, the yellow thing and the red thing. Both the things are there. So you may see two echogenic lines, echolucent or echodense. So then you should have it in your mind that probably you are dealing with both pericardial fat and the epicardial fat. Go ahead.
This is a subcostal four-chamber view where heat is accumulated anterior to the right ventricle along the RV free wall.
Rashmi, they will run. It's a video.
Okay. No, this is still image, ma'am.
But you
later on we have
okay
running clips.
Okay.
This is also still images which shows echolucent space, a black space basically over the right ventricle in the parasternal long axis view, and same here in the parasternal short axis view. It is here. So this is a parasternal long axis view in which some echolucent space seen here over the right anterior to the right ventricle. And as I increase the gain, it is more clear here. This is another study in which this echo free space, this is a four-chamber view, pericardial effusion is present along RA. This is a subcostal four-chamber view where epicardial fat is attached to the RV free wall. This is an mode image.
I would request the speaker to go back to the previous slide.
This one, sir?
No, the previous one. The subcostal one. Subcostal.
No, further back.
No. She has to go forward. She has gone too far
Forward.
back.
This running loop has, sir, subcostal four-chamber view.
No, he's asking about the
This is not the
subcostal
fourth
view.
chamber. This is the short axis view.
No, it will come, sir.
Yeah. Okay.
I will pause it.
Yeah.
Yes.
Yeah, this one.
So this one, sir. So this is a subcostal four-chamber view in which epicardial fat is present.
Can you play it? This is pericardial effusion. This is
No,
not epicardial fat.
Sir, there is some pericardial effusion, definitely. And along with this, epicardial fat is also present.
So
So
you
what
You are
she's
absolutely correct, sir.
what she's trying to show is that both the things are coexisting.
Yes. So you have to tell that.
Yeah.
You have to tell how to discriminate. Because
Yeah.
Yes.
the
So
audience which is present over here, they don't know how to discriminate between a epicardial fat and a pericardial effusion.
yeah, so we have a tabulated differences between these two. So after she shows it, but yes, Rashmi, you can always say like, look at the cavity, anechoic, ventricular
Yes, ma'am.
cavity. And
Yes,
similarly,
ma'am.
you are seeing an anechoic area as well as a echodense area.
Yes, ma'am.
Okay, so both the things are there, present there.
Yes, sir.
All right. So
Yes,
there is a
ma'am.
question coming, can it be a partially organized effusion? So in, whenever there are, see, in the epicardial fat generally moves with the myocardium. All right. But the organized, semi-organized effusions and all those, they may move independent of the myocardium.
Yes,
It
ma'am.
can also be a situation wherein you get fibrous bands, you get lot of, coagulum inside, and the blood inside, which is organizing in the cases of hemopericardium. So in those situations, wherever you are getting these kind of stuff, they will be moving independently. But the epicardial fat usually moves with the myocardium. Go ahead.
Yes, ma'am. So,
So Dr. Vivek, we will tell about the differences also at the end.
So I think this is clear that this contains pericardial effusion and epicardial fat, and they can coexist also. So I will move to my next slide. This is an M-mode image in which this arrow indicates the pericardial effusion posteriorly. Okay. And this arrow indicates this equiescent area, hypogeny, as pericardial fat.
Yeah, so we will talk about this little later. I will now invite Dr. Manish Bansal to talk about, subsequently any inputs, and I would also request him to show some more video clips. Dr. Manish, are you there? Yeah.
Yes,
Thank
yes,
you so
yes.
much.
I'm
Yeah.
there. So, Rashmi, you'll have to please unshare your slides.
Uh-huh.
Yeah. Okay. So I'll share my presentation.
Yeah.
Okay. So she's covered actually most of the important aspects through her presentation. I will just try to clarify certain things.
Yeah.
First is regarding the definition, and as we saw in the previous slides, it becomes confusing what is epicardial fat, what is pericardial fat, what is pericardic fat. And even in the literature, there is a lot of confusion. Different journals and articles have used different terminologies, but the one which is, as per consensus, most accepted is the one which I'm showing here. Okay, so here we have myocardium. Okay, then outside the myocardium, we know there is pericardium. Pericardium has two layers. One is fibrous pericardium, which is very thick layer outside the heart. And then inside this is a thin serous layer that is known as visceral pericardium. serous pericardium. So this is fibrous, this is serous. Serous pericardium has two layers, visceral and parietal. And these two layers are continuous with each other, and the serous layer winds around the origins of the great vessels to continue along the myocardium. So that is how we get two layers of the pericardium. This is known as visceral layer of the pericardium or visceral pericardium or epicardium. And this is known as parietal pericardium, which is a combination of two layers. One is fibrous pericardium and the parietal layer of serous pericardium. So together they are known as parietal pericardium. The space between these two is pericardial cavity. Okay. Now, epicardial fat is the fat which is situated between this visceral layer of serous pericardium and myocardium. So if I were to just move the myocardium a little bit away, the fat which is there in this space, this is known as epicardial fat. This fat is in direct continuity with myocardium. Then there could be fat outside the fibrous pericardium or parietal pericardium. This is known as pericardial fat. Together they are known as pericardial fat. So there are many other terminologies used. Some people have used the term peri-aortic fat also for fat which is around the aorta. But as I mentioned, this is the most accepted definition, that epicardial fat is the fat which is situated in direct continuation or direct proximity to myocardium and between the myocardium and the visceral layer of pericardium, and anything other than this is not epicardial fat. Okay. So I have some examples here. Rashmi also showed some good examples. So
Dr.
here,
Manish, I'm just interfering here in the terminology. So the epicardial fat also is included in the pericardial fat?
yes, pericardial fat is both pericardic and epicardial fat together.
Because in some articles, pericardial fat is dealt differently, which is outside, like, the fibrous pericardium.
Yeah, so in some articles, this fat, sorry, my pointer is not on. Yeah. So in some articles, this pericardiac fat is labeled as pericardial fat.
Yeah.
And this is known as epicardial fat. But as I mentioned, in most of the articles, which are considered to be the authoritative article on this topic, and even in the JACE review article from 2009, they have accepted this definition, and in all the leading journals also, this is the definition used. Epicardial, this is pericardiac, and together they are pericardial fat.
Pericardial. All right.
Okay.
All right. Thank
So
you.
as we can see here we have a layer of fat just outside the RV myocardium, and we can see this visceral pericardium here, and then there's another layer of fat outside this.
Yeah.
So this is going to be epicardial fat, and that is going to be pericardiac fat, and together they will be known as pericardial fat. I've got some more examples. So again, we can see fat tissue here. In this example, also fat tissue. Now, as there was a discussion happening about epicardial fat versus pericardial effusion, this can create confusion, and sometimes this epicardial fat may be mistaken as thickened pericardium organizing effusion, as one of the attendees asked also. But there are some ways to distinguish. First is that pericardial effusion is generally anechoic, as you had also mentioned. It is echolucent. In comparison, epicardial fat almost always has echogenicity, these granular appearances, because it is not fluid, it is fat. So there is some tissue there, which gives this echogenic appearance. So in this also we can see there is echogenicity. Here also there is echogenicity. Now this is a patient who had come to us a few years ago, obese lady from Uzbekistan, quite obese. When we made the peripheral long axis view, it appeared to us that she had significant pericardial effusion. But when we tilted the probe, what we saw was that all this which appeared to be pericardial effusion was quite echogenic and appearing like fat here. When we looked at IVC, IVC is completely collapsed. So to answer the question regarding organizing effusion, if there are no hemodynamic features of constriction, there's no septal bounce, no other hemodynamic features, and IVC completely collapsed, that will go against this fat being organizing effusion. Even though significant amount of pericardial fat can also cause constrictive type features. So it's not that it cannot cause constrictive physiology, but in general it doesn't. Then in this patient, we got CT done, and CT reported this to be fat. The radio density of this fat was totally different. It was quite radiolucent. So that confirmed that this was not effusion, this was fat. How to measure this? Rashmi has already discussed how it should be measured. And she showed this example also, again showing the same thing. This is epicardial fat. Now, in this particular article, they use the term pericardial fat. But again, I'll remind that both these together are known as epicardial fat. So that confusion remains. It is measured at end-systole. Why? Because this fat it gets compressed when the heart expands during diastole. So during end systole, when the ventricular chambers collapse, that is the time when we measure fat to avoid the effect of compression. Although some investigators believe that end systole may be the correct time to end diastole may be the correct time to measure, because CT MRI measure it at end diastole. So to have a direct comparison between CT and echo, some say that we measure it end diastole, but the consensus is that we measure it end systole to avoid the effect of compression due to enlarging cardiac chambers. Measurement should be done in plaques and short axis views. In plaques view, it should be perpendicular to the aortic valve here. And in the short axis view, it should be at the level of mid LV. So short axis images are not here. These are tilted images. Actually, that slide I forgot to unhide, but basically it shows that at mid LV level, we measure epicardial fat thickness in short axis, and in plaques, it is directly perpendicular to the aortic valve. Normal values, most of the articles have shown that in large studies, average epicardial fat thickness has been around 6 to 7, but in general, anything more than 5 is considered to be increased. These are CT and MRI images. CT and MRI give us more precise estimation of epicardial fat. With using CT, we can measure the volume also. In MRI, in this particular study, the mean thickness was 4 millimeters. So again, anything more than 5 will indicate increased thickness. Now, why epicardial fat is being discussed so much, something that Rashmi also talked about, is that it is unique. It is totally different from other forms of fat because number one, it is in direct continuity with the myocardium. It's not separated from the myocardium and vessels by any fascia. And it is also in direct continuity with the coronaries. So it can produce its effect on myocardium and coronary arteries directly. So these are the effects that she also mentioned. So I will skip this. But one thing which I would like to emphasize here is that in healthy individuals, epicardial fat secretes number of neurohormonal substances, especially adiponectin and adrenomedulin. Both have various favorable effects on inflammation, oxidative stress, myocardial function, endothelial function, coronary function, and so on. But when there's disease, when there's accumulation of epicardial fat, this changes. So first of all, inflammation itself is a trigger for epicardial fat accumulation, not just obesity. Obesity causes inflammation, that causes accumulation of fat around the heart, and simple inflammation without obesity can also cause epicardial fat accumulation. As you can see here, systemic sclerosis, psoriasis, and rheumatoid arthritis, again associated with increased deposition of epicardial fat in the absence of obesity. Obesity certainly increases the thickness of epicardial fat because of inflammation. So what happens is there are chronic systemic inflammatory disorders. They cause epicardial fat accumulation. And then epicardial fat becomes the site of inflammation. So it becomes a vicious cycle. And then it leads to coronary atherosclerosis, atrial arrhythmias, and HFpEF. These are the three conditions which are most closely associated with epicardial fat. I think I will skip these slides here. And this also was mentioned by Rashmi, that through lifestyle measures, some drugs, bariatric surgery, we can reduce epicardial fat thickness. In drugs, there are many drugs which act on epicardial fat, but those drugs which reduce epicardial fat volume as well as reduce inflammation. They are helpful in reducing the risk of HFpEF or heart failure or MACE rates. Like statins, they reduce fat volume plus inflammation, so they are beneficial. Insulin increases fat, so it's harmful. Sulfonylurea increases fat, harmful. Then DPP-4 inhibitor like sitagliptin, it reduces fat volume but increases inflammation, so it's not a good drug for heart failure. Metformin, SGLT2 inhibitor, and MRAs, all of these agents reduce fat volume, they reduce inflammation, so they reduce the incidence of heart failure also. So, just as a last slide, these are the quotes that I've taken from the article by Milton Pecker, excellent article published in JACC 2018. It says that epicardial adipose tissue may mediate deleterious effects of obesity and inflammation on the myocardium. So it is basically the local transducer of systemic inflammation, exerting its effect on the myocardium and coronary circulation. Thank you.
Manish, Dr. Madhav Bansal is asking to show you some previous. Madhav, can you clarify which slide do you want to see? Manish, excellent presentation, and you made the things very, very clear, because epicardial fat is not very well understood, that how dangerous can it be, and it is also modifiable. That is one important thing, and it is an upcoming marker. That is the third thing. So I think you have made everything very simple, and a lot of people have given you a thumbs up for fantastic explanation. And the first slide, in fact, I would also say the way you have explained with the help of those, serous and visceral pericardium, that was excellent. So I'm anyways very fond of your presentations, and this slide was excellent.
Yeah.
So I think
So,
whoever has not understood must have definitely, you have made the things clear, much, much easier for us and for me also. Whatever Rashmi has presented, you have much more clarified and extended it. So my question is, Dr. Manish, that should we report meaning 10 millimeters or 5 millimeters in our reports?
So when epicardial fat thickness is more than 1 centimeter, it has a strong association with the risk of heart failure with preserved ejection fraction, and we must report it.
Yeah. So the reporting should be whenever the readings are more than 10.
Yeah.
Is that right?
Even if we don't report the value, we can just mention that the thick layer of epicardial fat seen.
Yeah. So, and because, even though the person may not be obese, and we are finding it around 7 millimeters, so at least we can report it.
Yeah, there's no harm in reporting it. If we report it, we are doing better job only, actually.
Correct. And also, we can be making a lot of modified views to make it clear that whether it is actually a pericardial effusion or a epicardial fat, because you will see many a times that even the subcostal view, that makes it clear. The moment you will adjust your gains and you will modify your views, it will come out as like, oh God, what is this? This a huge epicardial fat.
Correct. So distinguishing it from pericardial effusion will not be that difficult, because pericardial effusion is just fluid unless it is a hemopericardium, water. So it has different echo density completely. Problem comes when a patient could be having tubercular pericardial effusion and now having organizing effusion, as someone had asked also.
Yeah.
But then in those cases, we have to use our judgment. We have to look at all the features, other parameters, and what the patient has come to us with.
Correct.
So just an obese patient undergoing echo and we find this, then we'll label this as epicardial fat along with pericardial effusion. And Rashmi had a very, very nice example of that.
Yeah.
If
And
both were
also
present.
and also whenever you are thinking of something to do with the pericardial effusion, meaning excessively secreting pericardium, also look for pericardial thickness, any kind of, history related to trauma, to tuberculosis, to
Yes.
malignancy. So, and also the IVC. If the IVC
Yes.
is normal, as Dr. Manish has showed, that the IVC is collapsed, how can you think about a pericardial effusion which is so huge and large?
Yes, and apparently causing RV compression also without
Correct.
affecting IVC.
Correct. So it should be a comprehensive approach, not just labeling it as quickly like, that it is this. And even, and sometimes when the things are not very clear, try to make a subcostal image and you will really find very good pericardial fat lying over the RV interior wall. So wonderful, Dr. Manish. Any questions from the audience? Thanks for your appreciation, from on behalf of Dr. Manish. Manish, lot of
No,
appreciations
I'm
have
happy.
come. Yeah,
In fact, I must appreciate you and the whole group and the presenters for doing this to organizing these excellent sessions, because this is what is needed for most people to clarify the basics. So it is very commendable on the part of our sonographers to come out and present to a large forum, and you and sir has also joined, and Dr. Vivek,
yeah,
everyone, to guide them.
yeah. Thank you so much, Dr. Manish, for enlightening us. Thank you, Thank you, Rashmi, for quickly taking my request to present epicardial fat. All right, and thank you so much for appreciating. We move on to the next talk. Dr. Sanjeevni, please, you're welcome to start with your talk, and welcome to the forum.
Just one comment. Can I make a comment?
Sure.
Pericardial effusion, number of times we say that IVC is dilated. We have seen a patient with large pericardial effusion with normal or a small IVC because over judicious use of diuretics. Whenever the patient comes to casualty, the people, they looks like they are in congestive heart failures. So they use a lot of diuretics in this subset of population, and we found that even IVC becomes smaller in this subset of patients. So
Yeah,
IVC alone will not be real answer sometimes when other findings are present. So we may ignore IVC at that particular moment.
Yes, great. That's also, which stage of treatment the patient is also important.
Which
So the
stage
use of medicines will, hide these symptoms.
Yeah, which stage of presentation basically.
Yeah,
Like
correct.
somebody walks into casualty with engorged veins and everything, the first thing a resident does is 40 mg Lasix. It's a normal phenomenon. Nothing wrong from that point, from their point.
Correct.
All right.
Yeah, and Dr. Sanjeevni is also going to again, emphasize on a very important part of the heart, which is like, often overlooked and often under looked, because it is difficult to actually configure. So my request to Dr. Sanjeevni will be that you please, make it simpler for the audience, and how they can configure, how they can interpret, and what is the actual interpretation of the graphs, because the Google images are different from what we get actually when we are interrogating the pulmonary veins. So please go ahead, Dr. Sanjeevni. She's from Pune, the Namdar Heart Clinic, and she's a wonderful teacher, I must tell you. So let's hope that, she is able to answer some of your pulmonary vein queries.
Thank you, Dr. Hansa ma'am. I'm very grateful to Dr. Rakesh Gupta sir for this beautiful activity, which has kept us updated to learn and practice art and science of echocardiography. Thank you, sir. And thanks for giving me this opportunity. Thank you, Dr. Manish, Rohit, Dr. Vivek, for this opportunity. So coming to this pulmonary vein Doppler, which is a new perception, that analysis of this with other echo parameters give added hemodynamic information about wide variety of diseases that involve heart. It gives important clue not only in diagnosis but also in prognosis of these conditions. So this is the left atrium, which is situated at the most posterior part of the heart, and it has two one right upper and right lower, and left upper and lower pulmonary veins draining into it, giving it a beautiful crab-like appearance, which is seen in transthoracic view, suprasternal approach. This is again, I am showing you again when the atrium is not opened, how it looks from the posterior aspect of the heart. This is the left atrium and all these four pulmonary veins draining into it. And when you see from the front side, you just see the pulmonary veins. You don't see the left atrium because it is posteriorly situated. This is another picture just to add to our knowledge how it beautifully looks like a crab. And when we take four-chamber apical view, these two are pulmonary veins which are seen, and this is the typical normal profile of pulmonary vein S more than D, and this is the atrial contraction. So one must understand that there is a continuous flow of blood from lungs to left atrium during systole, that is X descent, that is the pressure curves, that is S2 wave. S1 comes after atrial relaxation. And during Y descent, again there is a continuous flow, but the D wave is little smaller than S2. And when atria contracts, along with forward flow into the through mitral valve to LV, there is little blood flowing into the pulmonary vein, that is known as backward flow, that is called as AR or APV. So this is the most important slide of my presentation, where all these cardiac temporal events are correlated, that is ECG, LA function, LA pressure, pulmonary vein Doppler. I told you that S2 comes up during X descent, that is systole of the ventricle. D comes during Y descent, that is diastole of the ventricle, and when atria contract, that is atrial reversal. And last but not the least is this diastolic phenomena, where D is correlating with E wave of mitral valve, and AR, that is reversal, is correlating with forward A flow of mitral valve Doppler. These are very important because it helps us in diagnosing many conditions of the pathology. This is transthoracic view. This is four-chamber, where when aorta is closed, you see right lower pulmonary vein. When aorta is open, you see right upper pulmonary vein. There is a variation little bit here and there. And left lower sometimes can be seen in aortic sacs view, little off-centric. And these are transesophageal views, which I'll be showing you soon. And this is again when mitral valve closes, how S1 and S2 comes, and when mitral valve is open, how diastolic waves appear. And these are the normal velocities, which is usually less than 1 meter, usually around 60 to 70 centimeter per second. And this is around 40 to 50. So S2 is measured, not the S1. So age-related changes, we are seeing anatomy and now physiology. Age-related changes in pulmonary vein. This is a 18-year-old male with a very small reversal, but as the age progresses, there is large and tall a reversal because of various reasons: fibrosis, hypertension, diastolic dysfunction, and many things. So this is how diagrammatically it looks. SD should be more than 1, and when it is less than 1, it is abnormal. And this is again how right upper pulmonary vein is very, very, Doppler insonation is absolutely parallel, which is the prerequisite of Doppler interrogation. So this is usually done during transthoracic echocardiography, and this is transesophageal echocardiography. This is mid-esophagus four-chamber view, where probe is tilted towards left. You see this Cumadian ridge, this is LA appendage, and this beautiful left superior pulmonary vein with S1, S2, D, and atrial reversal. The same thing again, but I just wanted to show you how beautiful. You just push the probe inside, you see beautiful inverted V of left superior and inferior pulmonary vein. This is modified bicaval view, and probe turned towards right. Whichever is the organ to be interrogated, you have to turn the probe to that side. That is very simple. And these are right-sided pulmonary veins with beautiful profile. And one has to increase the sweep speed to get clear deconstruction like this. This is very important. This is what I told you about this crab view. This is suprasternal, taken into from the suprasternal notch in transthoracic with beautiful 4 pulmonary veins draining into left atrium, giving it a crab appearance. And this is the profile, how nicely one can get, if you are lucky, to even from crab view, this beautiful profile of pulmonary vein. And what are the prerequisites? So one has to follow these. That is, cursor should be at least 1 centimeter, 0.5 to 1 centimeter deep. Right upper pulmonary vein is easier in transthoracic. It should be in end expiration. Sample volume should be 3 mm. Sweep speed should be of 50 to 100. It should be exactly in the center of the pulmonary vein. And one should ideally take average of 3 values. If you don't follow this, you get this bad pulmonary vein Doppler. So this is again crab view I'm showing, and just labeled it to make it simplified, how beautifully one can take the pulmonary vein Doppler even from the crab view. And one has to take it from 2 sides to increase the specificity of these parameters. So try to take it from 2 different sides. I was very lucky, and I'm very grateful to Dr. Rakesh Gupta that he has taught us this so beautifully that I'm obsessed with actually echo. That this is the P-sax view at aortic valve, a little off-centric, but I got this left inferior pulmonary vein so beautiful with even S1 in transthoracic, which is many times is very difficult. Another important physiological change we must know that during spontaneous ventilation, there is decrease in feeling of LA in inspiration. We know that by 10%. IPPR increases LA feeling by 30% because there is reduction in the venous drainage to right side. So obviously left side is, there is more flow on the left side, and high levels of PEEP when you apply, whether chest is closed or open, there is decrease in systolic atrial feeling and there is decrease in S wave. There is hardly any change on D wave. This is another important concept one must understand before diagnosing diastolic dysfunction in any patient. See, this is the U-shaped distribution.
Dr. Sanjeevani, I'm just interrupting. Can you go back to the previous slide?
Yes.
The one with the respirator. Yeah. So can you tell them you are a cardiac anesthetist? Okay.
Yes.
So can you tell them what is the physiology that PEEP, works on these parameter? How
Yes.
does PEEP helps in changing these parameters?
Correct. But because of positive and expiratory, there is hardly any, during expiration, you expect decrease activity of the lung. But here we are applying positive pressure, so there is reduction in the venous return. So much so that there is always hypotension. One has to take care, and one should not give PEEP more than 5 centimeter of water or 10 centimeter. We have to look at the blood pressure basically. And whenever you give high levels of PEEP are required for many patients who are having less saturation. So one has to take care that there is decrease in the systolic atrial filling. So this S wave reduction is not due to raised LAP. This is due to your PEEP. That is most important, because otherwise you will think that S is less than D, so LAP is increased. That is not the situation.
So it is basically decrease in the venous return.
Decrease in the so many times there is fall in pressure, so one has to reduce the PEEP accordingly.
Yeah. Okay.
So here
Thank you.
I wanted to impress upon your mind that in very severe diastolic dysfunction, there is E by A more than 2, IVRT less than 70, S less than D, DT also less than 150. And in very normal, young, healthy individual with vigorous LV activity, also you find all these things, and tissue Doppler is the thing which differentiate it. So this is one of my patients where is a healthy young adult where I took pulmonary vein profile at 2 different sites, and at both sides it was less than D. So don't label, I just wanted to impress that don't label such normal patient. You have to correlate the whole, look at the bigger picture, correlate the whole scenario, and don't label them as a diastolic dysfunction patient. So there are systolic abnormalities. Now we finished anatomy and physiology. So there are certain systolic abnormalities and diastolic abnormalities. Today we will see few of them due to time constraint. So this is again how there are different reasons for S1 goes because of it is because of atrial relaxation. So whenever there is atrial fibrillation, it will just disappear. S2 is decided by LV contractility decreased by elevated LAP and even severity of mitral regurgitation. Then this reversal is again increased by LV stiffness or LVDP, increase in LVDP. So coming to mitral stenosis within sinus rhythm, there is prominent atrial reversal wave. Why? Because there is vigorous LA contraction against the stenosed mitral valve. This is large A. LA has to contract vigorously to overcome that stenosis. There is prolonged pressure half time of D wave of pulmonary vein, just like the prolonged half time of E wave. I told you that these two phenomena are occurring in diastole, so they are correlating with each other. So this is prolonged, and even E wave is also prolonged in mitral stenosis. And there is, whenever there is increase LAP, there is decrease in S wave velocity, which is not shown here. There is no increase in LAP over in this slide. So this is one of our patients. This is the apical 4 chamber. I have reduced the sector to increase the gain, and there is spontaneous pizza is also seen, and this beautiful pulmonary vein entering laboriously into LA. Obviously, there must be high LA pressure. And when I measured deceleration time of mitral valve E as well as D of pulmonary vein, they correlated quite well. That is what I wanted to tell you, that you can just correlate that how these two phenomena are occurring at the same time in diastole and behaving in the same way to the pressure changes in LA and LV. This is another case of MS and MR. How beautifully post-operatively S became more than D. See, this is the S and D before operation. The moment we changed the valve, there was S more than D. So it indirectly tells us that patient is doing fine. There are many surgeons who just look at the pulmonary vein nowadays, and if it is abnormal, they wait, give rest on the pump, or sometimes they go back on the pump and correct if something is to be corrected. Now, when we come to MR, it is not that simple that 1 plus 1 is equal to 2. It's not like that. By that I mean, whenever there is S is more than this, that doesn't mean that there is no mild, moderate or severe MR. It can, can be anything mild, moderate or severe. Still S is less than, more than D. Because there is sinus rhythm is there, then there is normal EF, vigorous LV activity is there. LA pressure is normal and LA compliance is good. This is still the patient is not, gone into a problem of which occurred due to mitral regurgitation. So when they go into atrial fibrillation or EF is reduced, LA pressure is increased, there is associated mitral stenosis, or LA compliance is reduced, then S starts becoming less. Even now, we are not sure, it doesn't guide us much, but whenever there is complete systolic reversal, yes, then it is highly specific, though the sensitivity is not that much, but it is highly specific that there is severe MR. And this specificity is further increased when you take profile at two different places. The same thing is shown over here, that how this starts becoming less and then it starts reversing completely. This is just the image. You don't get real scenario like how Dr. Hansa ma'am has said that these pictures you don't get. So this is what you get when you do it on patient, that this is the systolic reversal coming after QRS. Another important thing is that a systolic reversal must be seen in all the cardiac cycle to label it as a severe. When we tackle this MR, direction of the jet is very important, and that is why many times only RUPV is a better vein to interrogate than because of the anatomical situation than left pulmonary in transthoracic. So this is one of my patients with
Dr. Sanjeevani, I'm sorry, we will have to stop here because we have already eaten Dr. Rakesh Gupta's time, and we will continue in the next session. Okay, rest of the pulmonary vein
I'm sorry,
deconstruction.
Dr. Hansa, can we complete her topic? That'll be good.
It will be 30 more slides. She has 30 more slides.
Because even if I'll start, I'll not be able to complete my talk. It's only 9:30. So let her complete whatever.
So this time she completes it?
Yeah.
All right. All right. All right.
Okay.
Please go ahead.
Okay, thank you, sir. So this is a good LV activity, a small LA, compliant, and that is why S and D are absolutely normal, even though the MR is moderate, mild to moderate. But look at this case. This is again, sir, my own cases. I'm very grateful to you to teach me all this. This is again AML prolapse, PML flail, AML prolapse, severe MR, PISA over there, and in AF. And this is the same patient with AML prolapse and PML flail, huge LA. LA volume was more than 60 ml per meter square and complete systolic reversal. So this is definitely severe MR. So one should be able to differentiate between severe MR and mild and moderate. This pulmonary vein is very useful nowadays in mitral clip procedure. They have started using pulmonary vein as a routine measure, and low SD-VTI ratio. They have proved that the VTI ratio is better than only S and D ratio. And VTI ratio, when it is less than 0.7, it predicts recurrent MR and worst outcome. But during post-repair improvement in PV flow, that is the moment they put mitral clip and they look at S and D. If it is systolic reversal is converted to blunted signal or from blunted to normal, it is a best predictor of outcome than even your grading of MR. So this is the picture shown over here, that is systolic reversal complete before mitral clip. The moment mitral clip was inserted, both the S and D became antigrade, and even reversal is also seen. So this is they were happy that this was the successful mitral clip insertion. So now we'll start with diastolic dysfunction and pulmonary vein Doppler, very important topic. Elevated LVDP is the earliest measurable marker of diastolic dysfunction, and it precedes increase in mean LAP. So we measure mitral valve A wave and pulmonary valve A wave duration because they ideally should come simultaneously with similar duration. So that is why when the duration is more than 30 milliseconds, it predicts high LVDP with utmost accuracy. It is age independent, it is irrespective of AF, EF, and even in HOCM. So sensitivity and specificity are quite high, and this is how one should measure it. with reference to R wave. This is how one has to measure. This is the transmitral flow A wave, and this is the pulmonary vein AR reversal. So even if patient is not labeled as diastolic dysfunction, I am doing this, sir, and whenever I see the difference is more than 30 and I keep following that patient, eventually they land into grade 1 and 2 and they start showing those deformities. So this is how it reflects as the different grades of diastolic dysfunction are seen. Initially, S is more than D. Then in relaxation, that is grade 1, D is reduced. And the moment LA pressure starts rising, S starts decreasing and D starts increasing. And gradually, even this reversal goes on increasing. So it has not lost its importance even in British Society of Echo Guidelines 2024. It is along with left atrial reservoir strain, ARA duration, they have maintained its position, and even in whenever LVF is less than 50, even then it has maintained its position in these guidelines. Again, it has maintained its position in atrial fibrillation, BAC 2024 guidelines.
Dr. Sanjeevani, I'm just interrupting. Can you just go back and explain them this A and AR difference? What is it? A difference.
Whenever A has to be less, A duration has to be less than AR because AR is a small flow backward.
Yeah. So it is the difference.
It has
not
to
in
go
the
to LV.
Yeah. So it is the duration and
around 20-25% of blood is remaining in left atrium. In early filling, most of the blood goes because of the difference between the LA-LV pressure and relaxation of LV. And then there is a diastasis over here. There is hardly any flow during diastasis. And then atria contracts and the remaining 20-25 blood is pushed into ventricle. But there is some amount because there is no valve over there. So naturally some amount does go into the pulmonary vein. But whenever there is pressure difference between LV, LA, that LV EDP starts rising, naturally this forward flow of A across the mitral valve finds it difficult to reach to LV. So naturally it goes back. Wherever is the least resistance, it flows. And that is why the duration increases. Very sensitive sign before one gets frank diastolic dysfunction. So this is the earliest sign in diastolic dysfunction.
So there are two things, one is the maximum velocity of A reversal, and the other thing is the duration of the A reversal and the mitral A, transmitral A. Right?
Yes.
This everyone should understand that there are two parameters involved in assessing the left atrial pressures or the left ventricular pressures. These are two different things. Don't confuse with the velocity, maximum velocity of the atrial reversal from the pulmonary vein flow, and the difference between the transmitral A and the pulmonary vein A reversal duration. So these are two different things. You need to measure it differently, the durations and the maximum velocity. And Dr. Sanjeevani, will you be telling about them about the values which are maximum, beyond which it is considered to be abnormal? Yeah, it is here, I think.
APV and AMV should be more than 30 milliseconds. Some people say 35, but 30 milliseconds. And regarding velocity is a little less sensitive as compared to AAR difference.
All right.
So again,
but they should know that these are two different parameters and they should evaluate that way.
Easy to see even velocity, and of course, so this pulmonary vein Doppler has maintained its position in 2025 ASA guidelines along with LA reservoir hi-fi monitoring. So don't forget to interrogate them It is just over there. And this is where whenever this indeterminate group is there, along with LA volume and LA reservoir, pulmonary vein SD ratio is included in new guidelines. When we come to HEP-REF, the LA pressure is always increased, that is reduced ejection fraction, left ventricular reduced ejection fraction. So there is high LA pressure and S is always less than D in reduced. There is prominent D wave, prominent E wave, we know that these two go parallel. There is shortening of deceleration time of D as is of E. And APV and AMV more than 30, indicative of high LVADP. So high LVADP, high LAP, S2 wave influenced by LV contractility. Everything is easy in HEP-REF. But when it comes to HEP-PEF and high LAP, so if there is no high LAP, that doesn't mean that there is no HEP-PEF. That is, or there is no. So that's what they say that. If it is normal, that doesn't mean that there is no high. That is what they mean to say. Why? Because of hypertrophy of the heart, there is vigorous contraction, and so the AV walls are pulled up, and that is why S is maintained. But when S becomes less than D, it is absolutely indicative of raised LAP. But if it is normal, that doesn't mean that there is no high LAP. So what they have done, that systolic fraction, they have considered to put it as whether LAP is raised or not. It is very easy. You just have to trace S wave VTI, then trace D wave VTI, and if the ratio is more than 55%, there is normal LAP. So this is what they mean by sensitivity of the S and D in HEP-PEF. So use VTI instead of S and D. When it is less than 55%, LAP is more than 15, 90% sensitivity and specificity. This is intro. Okay. So this is what I have just shown over here, how the VTI of S and VTI of D are measured. Here I have measured them, and it is 68. So LAP is normal in this patient. But this SD ratio is not at all useful in atrial fibrillation, severe MR, and hypertrophic cardiomyopathy. This is very important, because many times in hypertrophic cardiomyopathy, it may be normal. So here we have to do AAR duration or APV and AMV duration. Again, very useful parameter is D wave deceleration. Very simple to do, absolutely simple. Steepness of DT correlates with LAP, 90% sensitivity and specificity. It's a very complicated formula, but to make it very simple, deceleration of D wave less than 175 is equivalent to LAP more than 70. Patient is bad. And deceleration more than 275, LAP is less than 6. Very simple. You judge the patient. If patient is breathless and having this DT, patient needs diuretic and other treatment. This is my patient again, sir. This is a concentric LVH, dagger shape velocity, dagger shape LVOT gradient. And look at the S and D normal. But when you compare APV and AMV, it is more than 35. So this is another patient where it is shown that it is 87 milliseconds. So in HOCM now one has to label along with these basic parameters AAR duration, because S and D ratio is not at all useful in predicting LAP. So if AR and A is more than 30, HOCM, it is always raised LAP.
Sanjeevi, we have 5 minutes left now.
Okay.
To wind it.
So this is
show them,
congenital heart, where in ASD, there is uncoupling between pulmonary vein and left heart. So there is this less distinct ascending wave, because the heart is this pulmonary vein are not at all facing the LV. Now it is facing the shunt and RA. So this is all are, you know, S and D are combined, and blunting of A wave due to reduced backflow. But fortunately, after operation, these become normal. This is another case of tubercular constrictive pericarditis, where again pulmonary vein can be of some help. This is the constriction showing how difficult the ventricle is getting to relax. And so we know that during inspiration there is reduced flow on left side, which is exaggerated in constriction, and this D wave velocity difference between inspiration and expiration during inspiration is more than 40%, which is not the case in restrictive cardiomyopathy. There are tall D waves and hardly any difference during respiration. And S is always S2 is absent because of the myocardial dysfunction. S1 is small, and tall and broad are reversibles. This is also last but not the least that pulmonary stenosis, it can occur during catheter-based pulmonary vein isolation for atrial fibrillation. Typically, it is turbulent flow and velocities are more than 1. And when it becomes monophasic, it is a high-grade pulmonary stenosis. So because we have started doing pulmonary vein analysis during surgery, and we are doing MICAS also, so many times, many people have saved the patient by looking at pulmonary vein. The moment they see turbulence, they ask surgeon to do the necessary things. So this is pulmonary stenosis. Now I just want last 1 or 2 slides. This is 50-year-old man with blocked bioprosthetic valve underwent redo MVR. And this was his pulmonary vein. Because of high LAP, it was very weak. This is the bicable with sagging LA, raised LAP and weak flow even on the right side. So the moment we changed the valve, what we saw was vigorous flow from the left superior pulmonary vein into LA, and with beautiful profile, indicating that patient is doing fine, LA is reduced, and one can come off bypass when you see all these things on table. So in conclusion, don't neglect these humble, highly compliant, thin-walled pulmonary veins, along with other echo parameters, not single parameter, along with other echo parameters. It gives added hemodynamic information about a wide variety of diseases that involve the heart. It not only guides in diagnosis, but also in prognosis, and some specific findings are predictors of this. Thank you very much.
Thank you, Dr. Sanjeevani. It was quite extensive. I'm sure at least everyone must have, gained something out of, so many data and so many information, so much of information. But that was great. And probably over a time, everybody, if practices it, something is going to come up. Dr. Vivek and Dr. Rohit, do you have any comments to make?
Well, that was a fantastic presentation by Dr. Sanjeevani. And I would say she has lived up to her reputation as usual, always.
Yeah. Correct. Dr. Rohit has, I think, left. So I think we conclude today's session. And just a message to everybody who is attending. If you have some good cases to present and you are willing to present some case here, do let me know. We would like to, make you present it and let everyone know some cases, which are of clinical relevance to all of us. So do let me know. And thank you so much, all the moderators. Dr. Rakesh has, I think, left. And I think everybody is just busy with the Kochi annual conference, right? So the moderators, the speakers, everybody is busy preparing talks for that, right? But thank you, lovely audience, to stay back for so long, hearing all this and appreciating us. Dr. Sanjeevni, a lot of appreciations have come up for you. And so you may thank the audience for that. And Reena, thanks again. Once again, each time I keep saying that, but without you, I think the program is not possible. So once again, thank you so much. And have a great time, all of you. Thank you so much. Thank you, Dr. Sanjeevni.
Thank you, ma'am.
Yeah.
Thank you. Thank you, Vivek.
Thank you. Thank you.